I'm Andy Reese, the Director of Department on Disability Services. We have a few things on our agenda today, including a brief presentation, brief call out, I think, from Kevin Wright from the DD Council regarding the upcoming Employment First Conference. Sean Ullman will provide some information about future planning for our Bridging Aging and Disability Network community of practice. Bernitras Parker from DDS will talk about our IDD waiver amendment. And then related to that, I'll give a brief update on our budget. So first up, I'll invite Kevin to share information about the upcoming Employment First Conference.
Hello, everyone. Good afternoon, everyone. Especially good afternoon to all the DDS fam. Good to see you all again. I'm just here to talk about information regarding the upcoming Employment First Summit. As you all know, so you all probably have seen emails out on your emails. You probably saw some information on the little DD Council social media posts. So that will be specifically on Facebook, LinkedIn, Instagram, and Facebook. Right now, we are basically offering submissions for everyone just to present a breakout session for the upcoming Employment First Summit. So hopefully I should be able to share my screen. Hopefully. Yep, there you go. So this is the little general information. Basically, it just has information regarding what time, the date of the Employment First Summit. So that is August the 8th from 9 to 1. Location gonna be at the MLK Library. Basically, this year, our theme is basically celebrating innovation, value, and talent. And this is just like a detailed description of basically what my little what basically information regarding submitting a proposal. So the Employment First Planning Committee and basically covered by the DC Development and Disability Council. Basically, we're looking for proposals that are 6 priority topics areas. So as you see right here, these are the 6 priority topics that we're looking for. You could submit for. Basically, the topics are the following: high expectation across a lifespan, building inclusive workplaces, transportation, technology and employment, resume building and career preparation, and progress on DC initiative and advocacy opportunities. So would you fill out the little this? Basically, you see like a section below where they're like basically what is the little topic that you submitted for. So you could just choose wherever from these 6 topics that you are basically choosing to submit a proposal for. Other information regarding is the proposal submission deadline. So the deadline for all submissions is next Friday, August the 29th, basically by the end of Friday of next week. And basically notifications of acceptance go out Thursday, September the 4th to everyone who was submitted. As always, if you have any question, you could either reach myself or Allison. These are our contact information and etc. And you have other basically information regarding the summit. And you could please reach out to either of us too. Hopefully by next week, the registration form should be going out. Hopefully. So just be on the lookout on that. And that's all I have for you all for the regarding the submissions. I'm about to put in the chat the link for you all just to go ahead for anyone who are interested in submitting the proposal. I just dropped that in the chat.
It's
But thank
already
you for
there.
your opportunity. And just to
Allison
let me
dropped it
share.
in the chat, Kevin, so thank you.
Okay,
So
thanks, Allison.
the link for people who are interested is in the chat, and it will also be posted on our website by next Wednesday. So next up, we have Sean Ullman, who will talk about the future planning for the Bridging Aging and Disability Network Community of Practice.
Good afternoon, everyone. Charlisa will hopefully be showing my slides here in a minute or a second. Thank you, Charlisa. So I'm here today to talk about a project of the DC Bridging Aging and Disability Networks and Racial Equity Community of Practice. I want to start by giving a quick thank you to the ARC of the United States, who allowed us to repurpose a lot of their educational materials on this topic of future planning. Next slide, Charlisa. So the DC Bridging Aging and Disability Network and Racial Equity Community of Practice is led by the DC Developmental Disabilities Council and the DC Department on Disability Services. We have 8 total partners. You can see them here on this slide. In addition to the council and DDS, we have the DC Department on Aging and Community Living, Project Action, RCM of Washington, Disability Rights DC, the Georgetown University Center for Excellence in Developmental Disabilities, and my organization, Quality Trust for Individuals with Disabilities. For those of you who don't know me, my name is Sean Ullman. I am currently the CEO at Quality Trust, where I've been in that role for about 3 years. The main focus of the community of practice is to better support people with intellectual and developmental disabilities as they age while maintaining their dignity and rights, to better support and connect with aging caregivers, which includes both family and paid caregivers, and to build the capacity for racial equity across aging and disability networks, and finally, to build sustainable relationships between aging and disability services networks. Now you can go to the next slide. So we're just giving a high-level overview today. The first thing is, when I say future planning, what do I mean? Future plans, you can see here on this slide, is creating a guide. It's focused on people with intellectual and developmental disabilities, although anyone with a disability could use it. And the goal is to create a guide to help them lead as good a life as independently as possible. And it's important for all of us to be thinking about the future, but for people with intellectual and developmental disabilities, it's really important that they're thinking about and planning ahead for the time when their parent or caregiver is no longer available. And future plans include things like a person's daily routines, their needs and supports, their current and future wishes for where they want to live, their current financial situation and how they want to plan for the future, taking care of their money needs, their medical information, their doctor's contact information, medical prescriptions they're taking, allergies, decision making, how they do it now, how they want to do it in the future, their educational history, and other details about their current employment, leisure activities, your religious beliefs, all the details of a person's life to help whoever their future caregivers might be. Next slide. One of the reasons why this topic is important, and we're trying to really highlight it right now, and it's a part of the community of practice, is nationally, there are an estimated 1 million households that have an adult with an intellectual developmental disability who are living with a caregiver over the age of 60. And more than half of those caregivers are between the ages of 51 and 79. In DC, there's an estimated 13,000 families who are taking care of a person with an intellectual or developmental disability. And based on the national averages, we estimate at least 2,500 of those families are over the age of 60. Knowing that, what's concerning is that more than half of those families report not having a formal plan in place for what will happen when a caregiver is no longer able to provide support. Next slide. And there are a lot of reasons for why people don't have those plans in place. One of the main ones is that they don't really understand what steps are needed to plan. They don't really understand what all's involved, and they aren't aware of what their options are, so they don't make plans. Another big area is fear about a caregiver's mortality, and a lot of difficult emotional reasons for not wanting to talk about that. Another challenge is people feeling like planning doesn't really apply to them, or they don't really need to, because they don't have any money or resources. And they don't think they can afford to talk to a planner or maybe an attorney or other professionals who might be needed. That's something we want to make sure people know. It's not just about financial resources and assets. It's a much bigger picture, planning for the future, and it's important for everyone to do it, no matter what your financial situation is. And the last reason people might not plan is that there aren't a lot of disability services available, and they're not sure what will be available in the future. So they're concerned about setting up a plan that might not happen. And there are some people who distrust the formal disability services available through the government and might not plan ahead for those services. So those are some reasons that it's people might not plan, and reasons we want to encourage everyone to get past those and plan anyway. Some important principles of future planning to keep in mind are that future plans should be made by a person and their team. And that team includes the person. We shouldn't be making plans for a person with disabilities. We should be making plans with them. It also includes their family members, their parents, siblings, and other extended family members. Their team might include their chosen family member and friends if they have people very close to them that they trust and want to involve in these conversations. And then their team might also include professionals, like their service coordinator or a case manager through another agency or their provider staff. Another important principle is that plans should be person-centered. It shouldn't be based on what is available, what we think might be available or might not be available. It should reflect the wishes of the person and the other important people in their life. Plans should be culturally and linguistically competent, making sure that they take into consideration the things that are important to a person culturally and based on their cultural backgrounds, and also that they're planned in a way that the person can understand and presented to them in the language that they speak. As I said previously, another important principle is that you don't need money or a lawyer to create a future plan. It's really important that everybody who is in a natural home situation or with an unpaid caregiver, or even with a paid caregiver, be thinking about what happens when that situation is no longer available. Although we will talk about a few areas where you might want a lawyer or other professional to help you as you future plan. Planning, why should you plan? It makes it much smoother and easier to transition when a critical situation presents itself to the person or their family. And the last really important principle is that planning isn't something you sit down and do one time, put all your documents together, put your wishes in place, and then set it aside in a drawer and never look at it again. Planning never ends. It needs to be regularly reviewed and updated because things are constantly changing in all of our lives. And those things need to be taken into consideration as people and their family members age. So the ARC Center for Future Planning and other experts in this area have identified 6 core areas of future planning. They include expressing wishes for the future, financing the future, employment and daily activities, deciding where to live, making social connections, and supporting daily and major life decisions. We're going to talk about each of these areas at a very high level today, really just kind of touch on them. But then we're going to share an opportunity later this fall where people and their family members can get help starting to future plan in these core areas. The first area, expressing wishes for the future, has 2 main tasks. First, families want to think about what's important and what's relevant to their personal situation, their history, their current situation, and what they want for the future. That conversation, the second piece of that, is that it should really reflect who they are in terms of their identities and their values and their beliefs. And then second, you want to start writing those things down and putting them in a plan. It's really important for the different members of the team to think about their own perspective and then talk about each other when sitting down and doing this first step of sort of assessing where we've been and where we are and where we want to get to. The next area is about financing the future. What matters is making sure that a person has the financial resources they need to live the life that they want and hope for. The financial resources that typically come into play in this conversation are the person's own resources, income from their own employment or from well, typically from their own employment or maybe money that they inherited. A second big bucket that's really important, particularly for a lot of individuals in the District of Columbia, is public benefits that they're available or that they're eligible for, and making sure that they've applied for and are receiving all of the public benefits that they need. And then the final resource typically comes from financial support from family members. And figuring out how all of those come together to set a person up for their best success. The next area, employment and daily activities. This is really a conversation that leads to hopefully some action planning for family members. And the kinds of things families should be talking about under this area are what jobs, what activities, what things, what tasks are important to the person. What do they like? What do they enjoy doing? What would make them happy and feel fulfilled? As well as what supports they need to do those things. So there's wanting to do something, and then there's having the supports you need to do them, including the kinds of accommodations that the person might need to be in place to be successful in their job or their daily activity. And another thing that's important to think about is sort of careers over a lifetime. So what a person is doing right now might not be what they want to do 5 years from now or 20 years from now. And what do they need to learn? What do they need to grow in their skills to be able to move into a lifetime career or a different career? Those are important questions and conversations for people and their families and their support team to have when they are putting together their future plan. The next topic is a really tough one, deciding where to live. some issues, again, that families should be talking about and discussing as a family and as a support team are the person's and the family's wishes for a future home. Where is the person now? Do they still want to be there in the future if their family member is no longer able to stay in the home and care for them? Or do they want to live somewhere else? And wherever that future home is, what kind of supports does a person need to live independently and safely in that home? There needs to be a conversation about what the housing options are and how we find them, and then how do we pay for them, which all of us know here in the DC area is a really significant challenge. They need to think about the transportation needs of the person and if where they live there is transportation to meet their needs, or whether they need to live somewhere else closer to transportation that can meet their needs, or find other transportation that can meet their needs. And then finally, thinking about what kind of home modifications or accommodations are needed to make a home accessible. Before we move on, though, the truth is that securing housing in DC is a huge challenge. It's a challenge for people without disabilities. It's a challenge for people of all socioeconomic outcome or levels. It's just a challenge. There are not a lot of options in the city that are accessible and are affordable. So when talking with families and when families are talking with each other, it's important to be honest. It's important to have empathy and listen and be supportive, but it's also important to be realistic and think about what's really possible so that people can truly plan for what's going to be available for them in their circumstances. The barriers to housing, specifically affordability, are not easily overcome, but it's really important that families are thinking ahead for future housing situations and planning for what's possible for them and their families. The next area of future planning is one that I think doesn't get nearly enough attention just generally, certainly in the future planning process, but even in sort of the person-centered planning process within people's individual support plans or other day-to-day conversations. And that is finding friends, having people that you're emotionally connected to and that you trust. It's we know from research that people with disabilities have less opportunities to create relationships outside their families. But what we also know is that expanded social networks typically lead to better outcomes for people. They feel happier, they feel more fulfilled, they feel like their life is really important and meaningful to them. And so, thinking about and planning for growing person's social networks should be part of future planning. And ways to do that are to think about the kinds of things they're interested in and ways to connect with other people who share those interests, whether there's, a cooking class at the center down the street, or whether there is an exercise class at the community center, or whether you belong to a church and there are other members of your faith community that you can connect with. These are all ways that you can start introducing and trying to grow social networks before a person loses access to their primary caregivers. And the last area of future planning is decision making. Something that anyone who's talked with anybody who works at Quality Trust knows is we want everyone to remember and know and understand that decision making takes practice. We don't always make good decisions all of the time. And that is true of people with intellectual and developmental disabilities as well. So it's important to promote, expand, encourage, and respect decision making as much as possible, grow it so that people can be their own decision makers for as much of their life as they can. For young people and for people under guardianship or who don't currently make their own decisions, you can start small. Start with everyday decisions that have very small consequences, like what time you eat and what clothes you wear and what activity you choose to do that day. Transitioning from school to adult services is a particularly good opportunity for doing that, because there still tends to be a formal support network surrounding the person with a disability to help kind of teach them and protect them from decisions that might have negative consequences. And then, of course, the other thing is to consider technology and how it can be used to support decision making. And as the slide here talks about, there's both informal and formal ways of providing support without needing to take away someone's decision-making ability. You can provide advice, again, provide technology to help people communicate, consult with them and help them make their own decisions, or set up formal decision-making alternatives to guardianship, like supported decision-making agreements, powers of attorney, healthcare directives, and even more formal ones like representative pays and limited guardianships. So decision-making is a big topic in future planning, and something that we talk about, and we can talk about more in the one-on-one event we're having, is regardless of how someone makes decisions now, you want to plan for how they might make decisions or need support making decisions in the future. And that can go both ways. Someone who's not making decisions now can learn and grow, get better at making decisions, and start making their own decisions with support. Maybe have a guardianship terminated if they're under a guardianship. And other people who are making their own decisions now, as all of us as we age sometimes can see decreases in our ability to make decisions. People with intellectual and developmental disabilities may also see decreases in their ability to make decisions. And so planning ahead and supporting them now to plan ahead for who they want to help support them or make decisions for them when they can't is really important. It's also important to support aging caregivers in doing that. If they are their family members' guardian or supporter, who's going to play that role when they're no longer able to? So there's a lot of different aspects of decision making that need to be taken into consideration when talking about future planning. So those are kind of the areas that people and their families might be worried about, might need more information about. Maybe providers are working with a family in that situation and they want to understand more what the choices are. The community of practice is making an opportunity available for individuals to come and get that kind of one-on-one support, talk about their individual circumstances, and what kinds of steps they personally can start doing to create a future plan. That event is going to be on Thursday, November 6th. It's going to be sort of an open house style. So we'll be there between 2 p.m. and 7 p.m. People can come anytime that they're available. We also have a registration form where you can sign up for a 30-minute slot to talk to someone and make sure someone's available to talk to you. It will be at the Martin Luther King Jr. Memorial Library on the 5th floor. That's at 901 G Street, which I believe is closest to the Gallery Place Metro. And individuals will have an opportunity to meet with a future planning navigator. And those are individuals that have been trained in each of these 6 topics to really know and understand them at a significant level and understand resources available to families in DC in these areas so that people can get some guidance and a starting point, at least have a first conversation if they've never had a conversation about this with somebody who's been trained and is knowledgeable. Allison, thank you for putting the registration form in the chat, or the registration link in the chat. We know this is an issue that is scary to talk about, but we hope that people will come out and really start thinking about what concrete steps they need to take and what kinds of information they should be putting in writing so that they can set themselves or their family member up for success in the future. So that's my presentation. Again, I'm Sean Ullman. My contact information is here and I can put it in the chat as well. If anyone has any questions, please raise your hand or come off mute or put it in the chat. Thank you.
Thank you, Sean. That was a lot of really good information. I was hearing some feedback, that's why I paused there. And looking forward to that event in November. And these slides also, we were sharing, so we already have them. Will be posted on our website next Wednesday, along with all the other presentations from today. And as indicated, if people want to click now to download the registration, it is in the chat. So if there are no questions, we will move on to our next presentation, which is Bernitris Parker from DDS, who will talk about our IDD waiver amendment.
Thank you, Andy. Good afternoon. I am Bernitris Parker, the DDS Medicaid Waiver Program Specialist. I apologize for not being on camera as it interferes with my audio, and I want to ensure everyone can hear me clearly. I will review the proposed changes to the People with Intellectual and Developmental Disabilities Waiver Amendment application. Next slide. The IDD waiver amendment will be effective January 1st, 2026. The proposed changes include adding telehealth service delivery, assistive technology ongoing extension service, companion 1 to 2 service, and 2 new services, health assessment and coordination, and state option to provide HCBS in acute hospital settings. Further proposed changes include modifying the scope of specific waiver services, DSP qualifications, QIDP qualifications and requirements, the modification and removal of performance measures, and set reimbursement rates for new and modified services and DSP living wage rates. This is a snapshot of the proposed modifications, and the highlighted information is specific to the IDD waiver. For assistive technology, we are proposing the following changes. Add the requirement for a technology plan when assessment is not required for assistive tech that costs under $1,000. Clarify that people 18 through 21 years of age who need assistive tech for medical or health-related needs must use the early periodic screening and diagnostic treatment service under the state plan before accessing AT services through the waiver. Next slide. Modify provider qualifications for professionals within a DDA provider organization who are not licensed assistive tech specialists. OT, PT, or speech clinicians will be required to obtain shifts enabling technology integration specialist certification to provide AT services. This requirement will ensure high standards of training and service delivery and ensure professionals are equipped with skills necessary for enabling tech assessment and integration. Also, incorporate the inclusion of clinicians whose specialty is in the area of tech is recommended in the support team planning process to ensure appropriate assessments and tech are per the person's identified clinical needs and increases the person's independence. Next slide. Add an extension service for assistive technology ongoing services. Modify allowable goods to allow the inclusion of 11 newer, more innovative technology categories that will replace existing covered goods to include but not limited to communication and cognitive aids, environmental control systems, and health monitoring and management devices. As technology evolves, new and emerging solutions that do not clearly fall under these 11 categories will be considered for inclusion on a case-by-case basis. This ensures flexibility in supporting the latest advancements in technology that align with the goals of enhancing independence and improving quality of life for people with disabilities. Lastly, adding subscriptions to acquire assistive technology, which refers to a model where a person can pay a recurring fee to access assistive tech rather than purchasing it outright, to allow for continuous improvements without requiring reinvestment in new devices or software. Next slide. For behavioral supports, we'll add the licensed professional art therapist credential as a qualified licensure to provide paraprofessional services, and clarify Tier 3 intensive behavioral supports and correct language to include changing the reference of participants to reflect persons. Next slide. For companion services, add the 1-to-2 ratio for people residing in supported living and residential habilitation residential settings who require this level of staffing to meet their needs during the day. Next slide. For creative arts therapies, annual limits for units will be implemented while removing the annual monetary cap as the number of allowable units decrease as the living wage increases, which can exceed the current annual cap for services. For day habilitation, clarify the staff to person ratio of 1-to-1 or 1-to-4 for day hab and 1-to-3 for small day hab traditional services. For employment readiness, clarify the staff to person ratio of 1-to-1 or 1-to-4 for traditional services. Next slide. Add a new service, health assessment and coordination, which is a standalone urgent care telehealth service that will provide specific medical advice on when waiver participants should seek additional or in-person medical treatment via virtual applications for people residing in host home, supported living, and residential habilitation settings. This service will provide a real-time health assessment to determine the best clinical course of action, often avoiding unnecessary emergency room visits, and is available 24 hours a day, 7 days a week by a licensed physician. The IDD waiver will cover the monthly service fee that is not covered through the state plan. The monthly unit covers unlimited access and unlimited calls to specialized physicians, physician assistants, and/or nurse practitioners for urgent care telehealth visits, and include all coordination, triage, and platform access provided by the physician. Any formal medical assessment conducted by the physician during a visit, such as diagnosing a condition or prescribing treatment, would be billed separately to the Medicaid state plan. Next slide. For in-home supports services, 40 to 56 hours per week will be considered based on assessed need if persons have significant needs and meet the criteria of support with ADLs, activities of daily living, behavioral support, medical, health, safety and risk, and level of independence. The requested hours must directly align with goals, activities, and outcomes and be proportionate to the time needed for teaching and support strategies as justified and documented in outcomes and goals in the ISP and in-home support plan. For example, if a person's activity is laundry, 3 hours per week must be indicated in the plan for the outcome and goal associated with this activity. The personal emergency response system will be removed as a standalone service as it is a service option under assistive technology. Next slide. Remove the requirement for direct support professionals to have proof of COVID vaccinations as this requirement has been repealed. For remote support services, we are proposing the following changes. Add the remote supports delivery to in-home supports at a staff to person ratio of 1-to-6 and increase the amount of time the service can be delivered remotely from 20% and cannot be offered 100% of the time the person receives the service weekly. Next slide. Modify allowable waiver services delivered through remote supports, which will focus on supporting independence and daily activities to include in-home supports, supported living, rehabilitation, employment readiness, and supported employment. Next slide. Modify the definition of scheduled check-ins to focus on the person's outcomes and wellness checks, which allows for a broader scope of support that is more aligned with individual needs, and modify the requirements for the monitoring-based and sensor alerts to apply exclusively to residential-based remote support services, as these services involve higher levels of consistent oversight and virtual support around daily living. Non-residential delivered services delivered remotely often do not require the infrastructure of a monitoring base nor sensors. On-call staff and backup responders are needed in remote supports for daily living, such as supported living and home supports, and the job coaching function of supported employment, where a person may be alone and require urgent real-time help. Next slide. Modify the requirement for providers to be shift certified as enabling technology integration specialists for residential-based and employment-based services, as the curriculum is specifically focused on remote supports in these settings and does not cover content related to the remote delivery of other types of services. Limiting the requirement to these specific areas will align the certification with its intended scope and avoid unnecessary barriers for other remote services. Also, the updated requirement from ETIS certified staff must be employed by a shift accredited service provider to ETIS certified staff must be employed by a DDS service provider relaxes the previous requirement that the provider organization itself be shift accredited, in addition to ensuring their staff responsible for oversight of remote support service delivery be ETIS certified. Now it's sufficient for the provider to be approved by DDS as long as they have an active ETIS certified staff responsible for oversight of remote support service delivery. Next slide. Lastly, limiting the remote support risk assessment and plan requirement to residential-based and employment-based services simplifies the administrative burden and targets the requirement to the most relevant service types. This ensures that the risk assessment process is streamlined and applicable to the right contexts. Next slide. Add telehealth services as a subcategory to remote support services and modify waiver services that will be provided through telehealth, which will cover professional, clinical, and therapeutic services to include the following services listed, and adding assistive tech assessment. Allowing AT services to be delivered remotely aims to improve assessment execution timeframes, ensuring that people receive timely evaluations and access to the necessary AT supports. Telehealth service rates will remain unchanged and will continue to align with the rates previously established for remote support services, and the shift ETIS certification is not required to provide telehealth services. Next slide. Add a new service, which is the state option to provide home and community-based services by direct support professionals in acute care medical hospital or short-term institution stays when the necessary non-medical supports are not available in that setting. For persons requiring assistance with communication, behavioral stabilization, and/or intensive personal care needs for IDD waiver participants receiving the following residential services and supports, which include rehab, supported living, and in-home supports on a case-by-case basis. Modify the supporting living service definition to specify criteria for the current utilization of supported living staffing only services for people residing in their natural home. Supported living staffing only services provide required supports beyond the scope of in-home supports, and without staffing supports, nursing oversight, and coordination, the person will be unable to maintain their independence and optimal health in the natural home. This service can be provided to people in a natural home who own or lease their home. Next slide. The proposed systemic changes include the following. DDS added the following requirement to the QDDP, QIDP qualifications: a bachelor's degree in any field with a minor in human services or an equivalent combination of education and continuing education courses in human services as approved by an accredited institution or board, and who has specialized training in intellectual disabilities or 1 year of experience in working with persons with intellectual disabilities or other developmental disabilities. DDS will explore and review courses, board-certified CEU topic areas, and CEU equivalency to credit hours to meet the human service minor requirement for QIDPs. Appendix C performance measures will be removed as DDS has consistently met this measure and is tracked using other systems. Next slide. Add qualifications training, competency requirements for home and community-based settings criteria, and PCP development for service coordinators. Modify the performance measure of the requirement for people to have an annual physical exam. IDD waiver recipients will be required to have an annual preventive health visit instead of an annual physical examination, as this data can be tracked by DHCF. The following Appendix G performance measures will be removed as DDS has consistently met these measures and are tracked using other systems. For Appendix I, adjust the DSP living wage rate to 117.6% effective January 1, 2026, contingent upon funding availability. The following Appendix I performance measures will be removed as the Department of Healthcare Finance tracks these measures using other systems. For Appendix J, add creative arts therapy services and rates. Add the billing rates for Assistive Technology Ongoing Extension Service, Companion 1 to 2 service, and the new services, Health Assessment and Coordination, and the state option to provide HCBS in acute care hospital settings. A final note, it is likely that IDD waiver will have a waiting list for waiver services starting the beginning of the new fiscal year, October 1st, 2025, and Andy will provide more information regarding this matter. I will also post the website in which the public can access the summary of the proposed changes to the IDD waiver, as well as where they can submit public comments. The public comments period for the IDD waiver amendment began August 15th and ends September 15th. If there are any questions, please feel free to put them in the chat.
So
Okay.
there are a few questions in the chat. Renitris, I'm gonna read through them and you can respond. Sandy, you might need to explain if your question was an ongoing question about every single slide or a specific question. She asked, can you please explain why you are making these changes? Was there a specific change you were referring to?
Well, can you hear me?
Yes.
Yes.
I mean, it went very fast, so I don't have a list of all of the questions I had, but a lot of what's being reported is that we're changing ratios or we're having different requirements, but not explaining sort of the reason why that is. I don't know if that's in any detail in a submission, because I feel what was sort of read is just sort of a list of the changes, but not, you know, this is why we're making this change. This is why we think we need this. This is why this change is being made to remote supports or to in-home supports, or to the, you know, to different ratios.
So there are no changes in the ratios. We are specifying ratios specifically for employment readiness and rehabilitation as in the waiver application. They're kind of vague. I believe at one point in time, our language was at the maximum ratio, and we just want to clarify what the ratios are for those services. The in-home supports 1-to-6 ratio is specifically for remote supports. So now that the in-home support service will be an official remote support service, most of our remote support services are 1-to-6 ratio. So that is an introduction to the in-home supports ratio. The companion 1-to-2 ratio is being added. It was formerly a flexibility in Appendix K during the public health emergency. And that ratio is very helpful to residential settings, specifically supported living and residential rehabilitation when people are at home during the day for various reasons. The reason why that we did a subcategory of telehealth services under remote supports is because we are changing the criteria as to what constitutes as remote supports and telehealth, as those services are different. However, telehealth is a subcategory under remote supports. We're just introducing a new category for those and also relaxing the requirements that are typically assigned to remote supports that are not assigned to telehealth services.
That's helpful. And I have a question coming up just since I'm already on. It was related to the supported living staffing services. And it said you had to own or lease, you had to be on the lease or own your home. I'm just wondering for people who live with family members or friends or something and aren't on the lease, or it's, they're living in a house owned by a family, but they're not on the title. Are you saying that they can't get supported living services?
It is my understanding that currently we offer this service already to people living in a natural home, and typically people who receive staffing only services live alone.
Well,
Is
that may
Shasta-
be, but I'm asking, I guess if there was a circumstance where I'm living with my mom, she owns the house, I'm not on the title, but I needed supported living staffing, can I not get it?
So if Shasta's here, she can tell you what the current rule is. I'm hoping she's here. She may not be actually. You do currently need to be, you can only get supported living in the home if it's your home, and you do have to be listed. I don't think that's a change.
It's not a change. It's just something that we didn't specify in our waiver, and we're just adding that language there.
Well, you
So we're
understand
adding
my
it to the waiver,
concern.
but it's always been in the rule. To be clear, it's always, so the waiver is being aligned with the rule, and the rule has always said that you can only get it if you are listed on the lease, you can get supported living. You can still get in-home supports in your home, but you can only get supported living in the home if you are named on the lease.
Right, no, but so I guess my issue with that would be, in-home supports may not be enough, especially if the person needs overnight support. And if I'm living in a home where my mom owns it or whoever, my aunt owns it and I don't own it, that I can't get the services. I'm just wondering what the reason for that requirement. I understand you want it to be the person's home and not where they're sleeping on the couch. But
The reason is to simply align what the waiver says with what the rule has said for quite some time. This is what the rule says. This is what we currently enforce based on the rules. So we're making sure that the waiver is aligned with the rules. It's a small number of people who get supported living in their own home. Next up, are people living in natural homes eligible for telehealth triage services? The slide said that people could receive the service in their own home, but did not seem to include people living in natural homes.
So this service is for persons who reside in supported living, residential rehabilitation, and host home services. And that the rationale behind that is that persons living in their natural homes either have natural supports and can access the service through their Medicaid, the state plan.
When is the proposed change for DSP vaccinations? I mean, the waiver change is January, but the regulation change already occurred. So once again, we're simply aligning the waiver with the regulation, right?
Yes. Yes, that is accurate, Andy.
And there's a question about when this is available, when the details of the submission are available. They were published in the DC Register and they will be posted on our website.
Yes, and I put the information, a link to our website in the chat.
So they are on our.
Andy, this is Robin Chafford. Can I follow up on my question?
Mm-hmm.
So the answer I heard was that this telehealth service that's offered through Station MD, is that available to people through their state plan services, through the Medicaid state plan? Because my understanding was that it was only available through the waiver. So I'm confused.
Go ahead, Bernitris, if you're going to respond.
There is an assessment component that is available through the Medicaid state plan for telehealth services. This service specifically links persons to a physician to discuss their symptoms with the physician. to determine if they will need to be directed to an emergency room,
Yeah,
or if they can be treated.
I understand what the service is for. I've been to multiple presentations that DDS has had about the Station MD service. What I'm asking is, both in the original question and in the follow-up, are people who are living in natural homes eligible for this support through Station MD?
No.
Thank
No.
you. Thank you. I
That's the
understand
quickest
the answer now.
answer. So no, they are not. We briefly during COVID provided it to people in high intensity in-home supports. But at this point, we're only offering it to people in residential placements with DDA.
Okay, so the slide that said that it was available to people in their own homes, you should clarify that.
Thank you.
It is clarified. The setting specifically says host home, supported living, and residential
Right.
rehabilitation.
So that to
And
me
it can be
means
provided in their homes,
so
living in those residential settings.
what I'm telling you is, as a reader and a listener, that was ambiguous. So if you want to leave it the slide being ambiguous, that's your choice. But it was confusing to me because it said two different things on the same slide. So I was just suggesting that I may not be the only person who was confused, but if you think it's clear to everybody except me, that's your call. Thank you very much. I appreciate the clarification.
Okay, thank you. Can a QDDP qualify with a bachelor's degree in a non-human services field, provided they also hold a certification from a nationally accredited body with a focus on supporting individuals with intellectual and developmental disabilities?
So, as mentioned during the presentation, DDS will consider those who does not have a degree in human services. However, there is going to be a requirement for them to at least have CEUs or a minor in human services in order to be QIDP qualified. DDS will be working on having information as to which CEUs and minors that would be qualifiable for QIDP qualifications to meet that requirement.
Oh, so Mark included the language from the regulations related to supported living in a person's home. And then there's a question. It was mentioned, correct me if I misheard, that individuals or companies with ETIS certification can oversee remote services. Would certified assistive technology professionals also be eligible to oversee remote services?
So yes, you heard me correctly. ETIS certified providers and staff can oversee remote services. The shift requirement is still, the ETIS is still required for residential-based and employment-based remote support services. For the assistive technology professionals, and I'm sorry, I'm just going through my notes so I can make sure I provide you with the accurate information.
Donald's here and he has his hand up, so you might want to just let him.
Yes, please, Donald.
Yeah, great work, Benitris, and good afternoon, everyone. Just to state, with that remote supports and the ETIS cert requirement, it's very important that that cert is acquired because we can guarantee that in the curriculum, they do cover best practices around remote supports. And we can't quite do that with AT specialists. I don't think that is in their certification to have those best practices to provide effective oversight of the delivery of remote supports.
And just to specify, for assistive technology services specifically, we modified the provider qualifications that people who are not licensed assistive tech specialists, OT, PT, or speech clinicians will be required to obtain shift enabling technology certification to provide AT services specifically. Just so that I just wanted to clarify that point.
Any other questions? Okay, and the link is here to be able to review the public document, which also includes a link where you can submit comments or questions. The 300 and some page document. Hopefully this presentation has given you sort of, it helps with being able to review that long document.
I have a question actually.
Yes.
And I'm thinking writing it may take some time. So is there a way that DDS can team up with any able body such as Coalition or anybody to come up with a certification program for QDDP? So that way we'll have a CDDP, certified versus qualified, for people who do not have a degree in the human services field. And by me saying that is because there are a lot of people, as everybody know here, who are very talented, who has acquired a lot of knowledge and experience throughout the years. Yet, boom, they're told they're no longer qualified, they can no longer be a Q, and they may even have more knowledge than people who are qualified to be a Q. So that way we'll have more like a certification program for people who do not have this human services field. Is that a possibility, or that would have to come entirely from a private entity and DDS cannot get involved in this?
I don't know that it's that DDS cannot get involved with it. It would have to be something, we are defining what the parameters of that training would have to be. But providing the training ourselves is not something that we're in a position to do at this time. But we have in this waiver offered considerably more flexibility about the requirements for a QIDP, so that someone with a bachelor's degree in something else could take additional. I don't know where we are with defining the specifics, and Bernitris, you may need to help me. I know that we've looked at the areas of the training that people would have to have in continuing education in order to qualify.
Thank you.
Yes, that is an initiative that DDS Quatma is working towards to be completed prior to the effective date of the IDD waiver, or October 1 specifically, because it is also applicable to the IFS waiver. So I believe that Quatma is looking into reviewing courses and CEU credits to provide that information to the provider community, so you can have a more clear picture as to what qualifications and criteria that will meet the QIDP requirement. So I will defer to Shasta Brown if she's present for any status on that endeavor.
She's not.
Okay, sorry.
Okay, any other questions? So lastly, I just wanted to confirm for people information that I think I've shared previously. Related to our budget, which is that unfortunately, the council included in its final budget specifically a reduction to what the administration said was the needed increase for our IDD waiver. The reduction from council was a little over 1.6 million. And given that council is not fully funding the waiver growth that's been projected by DHCF and DDS, that's going to require that at the beginning of the fiscal year, we will need to be implementing a waiting list for services. I think that the council budget office, in looking at DDS's budget over the last few years, was looking, when it looked at the waiver, it looked only at local expenditures. And its view was each year you had this surplus, and then the next year you asked for an increase in the amount you needed. And then once again, you had a surplus. And what the council budget office seemed not to recognize or take into account was that COVID happened. And included with that was the CARES Act, which included an increase in the federal share that was paid toward our waiver, and an increase in the federal match of 6.2%. When you spend overall, approximately, it was over a few years, so between $320 and $370 million on waiver services, having the federal government increase their share by 6% is a pretty significant bump. And so, to clarify, I feel like I've clarified this a number of times, but obviously not enough times. DDS and DHCF work together to do our waiver projections of the funds needed in a particular fiscal year a year in advance. And so, for example, we will be working with DHCF in October, November for our fiscal year 27 waiver projections. What that meant as we went through COVID was, obviously in FY20, no one predicted that COVID would occur. And so our FY20 budget didn't anticipate that for 3/4 of the year, we would get an enhancement in the federal match of 6.2%. And therefore, we actually had a surplus of funds as we went into COVID. We did, with our Appendix K, it increased our costs some, but it didn't increase our costs that it cost the whole 6.2%. And then each year, as we were projecting a year out, our projection would be based on an expectation that the federal public health emergency would end, which would mean that the local share would return to 30% as opposed to 23.2%. Excuse if my math was wrong. As opposed to 23.2%. And that 6.2% additional funds, as I said, in federal funds was substantial. The other thing that wasn't accounted for in our projections was that the American Rescue Plan Act passed. The American Rescue Plan Act included a 10% increase for 1 year, which was from April 1, 2021 through March 31, 2022, an enhanced federal match. So we had a 16.2% bump. Because of those, we saw surpluses in our local funds, which at the beginning of each year, as we saw that the public health emergency was not in fact ending in that year, we would do a revised budget, and our actual numbers came fairly close to the revised budget, because the revised budget was based on the realization that in fact this public health emergency is continuing. It, as people know, continued from middle of March 2020, when we said we were going to shut down for 2 weeks, until I believe it was May of 2023. And the enhanced FMAP continued all the way throughout that year. So that made projecting challenging. What we did know, and I think I have covered in budget, in budget forums here, is that overall, our waiver growth has increased at a rate higher than the consumer price increase each year. We've seen on average over the last 5 years, an increase in our waiver expenditures of about 8.5%, which is significantly above the 5.5% over that same 5-year period in the consumer price index, that increase. And so I have sent out something in the last week, and I have spoken about this before, talking about the fact that we have to come together to look at what are the drivers of that waiver growth. How is it that it's growing beyond the costs simply of we have added more people. The expansion, of course, increased our costs. There is some inflationary impact, but there are also aspects of how we're providing services that we see growth in the waiver that outpaces the cost of inflation or the increase in the number of people that we add to the waiver. And so I've sent something out. I expect everyone here has gotten it because you're all here, and it did go to this group. We're looking to have conversations over a 6-month period where we will talk about what are the growth drivers in the waiver, what are some changes that we might be able to make so that we can address this significant growth that we've seen as long as I've been here, where it just keeps going, and ensure that in the future we can address this issue of the waiting list. Beginning in FY26, we're going to have to implement a waiting list. My hope is that we'll also be able to talk about how to eliminate that waiting list and move forward, so that we can make services available for all people who require those services. Our plan at this time, the Appendix J will be published and people will be able to see how the waiting list will be implemented. Our plan is that it would be just in the comprehensive, the IDD waiver, and that the IFS waiver would remain open in order to provide some services to people as long as we continue to have slots in that waiver. And as I say, we will begin, so in the communication I sent out, we will begin in September to have these monthly meetings. We'll have 6 meetings. They'll be focused. We will have homework between the meetings where we'll provide data to people so that we can make informed decisions about some proposed changes to our waiver, looking at another amendment beginning most likely January 2027, so that we can ensure the sustainability of these services and the availability, because this next fiscal year will be the first time that we have ever had to implement a waiting list for services in our waiver. As I had said in my budget testimony, Mayor Bowser really invested significantly in DDS. We saw a 14% increase in our local funds to ensure that we could continue providing services for all people who need them. So as I say, I hope that together we can look at this. We can't go into a year where OCFO is projecting that there's not adequate funds and say that we hope that they're wrong. We have to take action and do planning based on the analysis that has been done. And so, we will be providing more information about that in the next couple of weeks. And as I said, we have sent out the invitation. We will begin in September to have our discussions about how do we move forward in a responsible way to ensure that these really vital services for some people can be made available to everyone who needs them. I don't know if there are any questions about that. So as I say, I'll be sending out more communication in the next week or two. And it is really, from my perspective, disappointing news to share. See, there's a rather, I have to close out people so I can see. So there is a comment here from the council member staff person saying, thank you. This isn't a question. I would just like to share for those online, the Council Committee on Facilities and the Office of the Budget Director, which is in the council, does not believe DDS must implement a waiting list at the beginning of fiscal year 26. An analysis of current and past waiver spending and as I said, and we don't have to go back and forth, that analysis is flawed. I didn't say it that directly, but I will. That analysis did not take into account the effect on our budget of COVID, of the enhanced FMAP from the federal government. And these are the conversations, quite frankly, that we should have been having in a budget hearing. If there was going to be a reduction that based on the Department of Healthcare Finance's projections of the needs of the Office of the Chief Financial Officer's calculation of our needs, to say we don't believe you need that much isn't enough of an analysis for us. And I'm sorry, I'll go on and read the whole thing because there may not be people who have access to being able to see what is being said. The council, the budget director does not believe that DDS must implement a waiting list at the beginning of fiscal year 26. An analysis of current and past waiver spending indicates getting to the point where 1.6 million would be necessary would require a massive and unprecedented increase of waiver utilization that surpasses previous years, as well as the growth rate for next year. If anyone is interested in this analysis and explanation of what disability-related cuts the executive made that the council was able to restore, making this 1.4% reduction in waiver services, please email the Committee on Facilities. Oh, I'll clarify, the council restored the $1 million to providers. And I believe that was all the council restored in our budget. So the council, everyone is certainly free to contact the council member's office. The email is here. You can contact the council's office to get their explanation. The reality is we are constrained by the budget projections that we have. And based on those budget projections, we take action. For us to act in a manner not consistent with what OCFO has advised is not allowed, to be clear. In the same way, I did hear the council's final discussions about their budget. The council had to make changes to the budget based on advice from OCFO that they were required to follow, because OCFO ultimately does have the authority to provide information about the adequacy of funding in the budget. And so we are taking action based on OCFO's analysis. And, you know, if it turns out that we're inaccurate and that there's extra funds, then we'll be able, you know, we monitor this every year, every month, I'm sorry. We monitor it every month. We have a financial review process, a memo that the council receives that they would see this fiscal year. Actually, we've had spending pressure on our waiver since the spring. So, you know, this year we're struggling to get by. And so if we see next year that the council was correct and that in fact there's a surplus, then we'll be able to start moving people off that waiver. No one would be happier than me to learn that those projections were inaccurate. As I said, all of these conversations would have been conversations that I would have liked to have had during a budget hearing. Okay, so if there are no other questions or comments, have a nice weekend, everyone, and we will be talking again. Thank you.